we're really fortunate to have such great representation here today. It's been a great conversation so far, but ultimately it's our health insurance companies that are accountable for the health insurance products we buy and the prices we pay for those products. Alex Feldvebel, the Insurance Department's Deputy Commissioner, is going to moderate this panel. And Alex, I'll let you introduce the panelists and moderate the panel.
Very much, Roger. So this is the third and final panel of the day. Yes. It'll be most challenging in a way because it's starting to feel like a long day, and we've all been inundated with a lot of good information. So let's make this interesting, guys. We have Dr. Bill Brewster from Harvard Pilgrim and Afraim Botros from Anthem. And I'd like to just start by having you guys talk a little bit about your background. You're here today to represent the carriers, but you each have background that makes you particularly well qualified to speak to this group. So just a minute or two on the background, starting with Bill.
So I'm an internal medicine doc by training. I just went to my 35th medical school reunion last weekend at GW, so I've been around long enough to see a couple of changes, both in terms of how big a formulary could possibly be, and oh my God, how much things cost. I'm from New Hampshire. I think I have a unique background in that I've practiced in New Hampshire. I've been in solo practice and paid my own salaries and my staff salaries. I've been an employed physician. I've worked for a quality improvement organization. I started and ran a fuel oil company with my wife. So I've had to have employees. I've done workman's comp. I have headed up an independent physicians association and negotiated contracts with the payers. I used to say against the payers. Now I say I negotiated them with the payers. And 4 years ago, I came to Harvard Pilgrim as the medical director. No inkling I would ever be working for a payer. I had no problem doing that, but it was just one of those things that sort of I fell into and felt that it's very easy to stand outside of an organization and complain. But I felt that being a part of a healthcare payer gave me a clinical voice into something that I had enough knowledge about to be trouble and figured that I could be educated. So that's me. And about just approximately March 9th this year at 1 o'clock in the afternoon, we had some organizational changes and I became the VP of Operations for the New Hampshire market for Harvard Pilgrim, which means that when things go really well, I have an incredible team, which I do. And if they don't go well, Bill, what the heck happened? So been involved in this. So that's me.
Great summary.
I had more of a clinical start into the industry. I started my practice as a clinical pharmacist in a hospital in New Jersey. I transitioned into the managed care industry, started working for a PBM known as Express Scripts, or ESI. I worked for them in clinical criteria, PA, more on the clinical side rather than business. Anthem is really my transition into the more business aspect, but still mostly clinical. I transitioned to them in July of this year, so fairly recent. My experience shows me more of the PBM experience versus the payer, so I will bring some of that to the discussion today.
Thank you. Thank you. So I'd like to start by kind of trying to quickly sum up some of the information that we've learned today, and then trying to offer you guys an opportunity to tell us what can we do about all of this. So we learned this morning first thing from Jennifer Smagula on behalf of Gorman Actuarial about what's going on in New Hampshire with respect to pharmacy costs. And we learned that the inflation in pharmacy costs is significantly higher than medical trend overall at 8.7%. And that the overall spending in New Hampshire is at about 19% just for the prescription component of the medical costs. And that doesn't include drug spending that occurs in the hospital outside of the formulary context, and that might be another 8 to 10%. So we're talking about a significant portion of medical spending that is on a growth path. Then we also learned that it's not so easy to determine the value of new drugs as they come on the market. We have a lack of studies. Dr. Abramson was arguing as to sort of the comparison lifestyle change benefit compared to the drug. We have a lack of access to the clinical trial data that does exist. And so it makes it very challenging to develop the cost-benefit information. And we heard from Sarah Emond that there's an organization that tries to do just that, and they have buckets of information and holes, and there are a lot of holes, and they're doing the best they can. Then in the PBM discussion, we learned that we don't have a perfectly competitive marketplace either. There are a number of anti-competitive factors that are at play in the pharmacy benefit arena. One, Dr. Abramson referred to the influence of politics and power in sort of determining what happens and whether there is research on the cost benefit. We know that there's a lot of access to information. Competitive markets require easy access to full information as to price and quality. We have phenomena such as direct-to-consumer advertising that arguably doesn't promote a competitive market based on cost and value. And we have, of course, we have patents for new drugs, which give the patent holder the monopoly power. Well, that's not a competitive thing in itself. There's certainly a good reason for that to exist. So we have a market that, in many ways, isn't perfectly competitive. Then we have health carriers, and I'll give you my view of the role of the health carrier. It's primarily to be an entity that aggregates bargaining power and competes with other similar entities to provide the best value for the consumer, which is either the employer purchaser or the ultimate consumer, the member. So here you guys are as aggregators of bargaining power, trying to deal with this issue of the pharmacy benefit. And I'm going to give you like a free-range question, which is, well, starting with you, Afraim, what are your what's your strategy? What are your challenges, based on all the discussion you heard today, to confer the best benefit you can for consumers?
I don't know if I could give you the whole picture,
Yep.
but I will definitely try. The way I see the process the payer goes through, plan goes through to leverage that bargaining power to the advantage of the consumer is the payer has to balance a few things. They have to balance their consumers, first and foremost. They have to balance their negotiations with the pharmaceutical industry, the drug manufacturers, wholesalers. They have to leverage their relationship with legislators and government to make sure that they're operating within the scope of government, but at the same time that government isn't legislating so much that they can't do their job and provide a quality service to the consumer. To balance all those three parts, I think, is the challenge for the payer. How do we get the best drug prices that we can for the best drugs that we can to treat the patients and to provide a quality service, a quality benefit to our clients. And I think when one area is heavier than the other two, the payer has to make room somewhere. And that's, I think, part of the challenge that payers face today.
What do you mean by one area heavier than the other?
So, for example, a pharmaceutical company comes out with a brand new drug. The drug is available in the U.S., so there's no issue with legislation there. But the drug is very, very expensive, to the point where, for example, we were speaking about Hep C earlier today. To pay for one new Hep C drug today is going to take a certain amount of capital. The capital has to come from premiums from multiple patients. A sample Hep C drug today, for example, Harvoni, to pay the ideal, and by ideal I mean the most reasonable in terms of cost, cheapest drug price for Harvoni to treat one patient today, you have to use the premiums from 8 patients. So that's saying that you have to balance treating one patient while the premiums for the other 7 patients in that 8 patient range are going towards this one drug. That means that whatever therapy the other 7 patients are receiving is coming from you, the payer. In some cases, there may not be any because the other 7 patients are not using. In some cases, there may be a lot more cost because the other patients have other health conditions, etc. So it is a balancing act. You have to see what the drug price is, how the members are using it, and how you can provide the members with the drug at the cheapest price, assuming that this drug is a quality drug and that the member needs it.
So you're kind of echoing this theme that there are limited resources, and as these new drug treatments come online, one way of evaluating it has to involve the sort of opportunity cost. What are you losing in terms of resources that need to be allocated to other people with other conditions? Okay. Bill, do you want to?
So, at the risk of sounding nirvana-like and or too optimistic or idealistic, I think one of the things is we and I say we, Harvard Pilgrim, my experience over the last 4 years is that we really are trying to develop partnerships so that everybody feels like they get a voice at the table. That's our providers. We've partnered with providers in the state with our Benevera Health Population Health model. We partner with providers outside of the Benevera Health model. We really try to get people to come in and discuss with us, whether it's with our value-based formulary that we have with the PSCK9, the pesky nines we call them. We have a value-based contract where if it doesn't live up to what at least the study says, which we all know the studies aren't perfect and they may show what they need to show to get the drug approved, we try to partner with them to have civil discussions about that. We participate on boards. We work with the insurance departments. We really try to get out there so that my feeling is, and again, I'm just a kid from New Hampshire, is that when I start to get yelled at, I don't listen. Nothing changes. I either decide whether I have to fight or run away. And so we really try to get those discussions going on so we're not laying blame. I could see people at different times sitting up front getting defensive and getting uncomfortable because it is very easy to blame me as a consumer because for years I had an Anthem J plan that didn't require me to pay anything or know anything about anything. And still we do protect. That's what insurance is for. My house burns down, I don't want to have to pay for it or no. I want to know it gets replaced. But again, I could be blamed for that. I could be blamed for the entire opiate crisis because I've overprescribed narcotics because I was listening to somebody saying I had to pay attention to the pain index and pain control, and that was a patient experience survey. And as a payer, we just don't want to ever pay for anything, and we're hoarding this money, and somehow, even though we're not for profit and it shows up what we make. So we're having to have those discussions, and then we look at what is safe and efficacious. I will tell you honestly, it is first and foremost, does this drug do what it's supposed to do? Does it fill a niche that's not been filled before with our members? It goes beyond just FDA approval, but we start with that, and we look for 18 months ahead of time to try to figure out what's coming so we can prepare for it and look to ICER and look to other people for that. So, our strategy is really to just try to stop pointing to lay blame, because it's very easy to do, and figure out how do we work for it, because I think we all in the room agree that it could get better than what it is. And there's so many dollars involved in it that if we don't pay attention, it can impact all of us and disrupt healthcare, which as a healthcare provider, I don't want to see that happen.
one aspect of this is the PBM. What is the value of a PBM? You get to answer that one first, Afraim, because you worked for one 6 months ago, or
Yeah.
okay. So,
What is the value of a
but from the
PBM?
carrier's perspective,
Okay.
as opposed to just contracting directly,
With the patient.
with the drug manufacturers. I mean,
The PBM serves a lot of functions. I would say the first function it serves is operations. It takes a certain level of operations, certain number of people to run a pharmacy benefit, to administer it, to have contact with the patients, contact with pharmacies, specialty drugs, etc. Operations definitely an area where I think PBMs serve a role for payers, so that the payer doesn't have to build the operations needed to administer an entire pharmacy benefit. The other function is relations with pharma, with drug manufacturers. Oftentimes, PBMs take care of that part, not all of it, and certainly not most of it in some cases. Depends on the drug class, depends on the drug manufacturer, etc. In some cases, the PBM takes care of that role in terms of negotiating the price, the best price. And it can get a better leveraging position, bargaining position than the payer, because it has several payers on its side that it's negotiating prices for. So it increases the negotiating power of a payer by bundling several payers together. That is the second role. I would say the third role, and the role that it's really should come first, is the consumer contact. Making sure the patient is educated about their drug choices, making sure that they're getting their drug through the correct avenue. If the patient needs the drug through a retail pharmacy, or if the patient needs the drug through a specialty pharmacy because the drug's not available at a regular retail pharmacy. Most PBMs today have their own specialty pharmacy division for patients to get their drugs through that are specialty drugs. So I think that's also an important point of why we need a PBM.
okay, now I'm going to ask you a more complicated question. So the value of what is the value of PBM, especially from the perspective of aligning incentives? Because we've had a number of panelists today talking about what's important here is that the different players in this arena need to be aligned. And Bill, you talked about partnerships, and I think that's another way of saying the same kind of thing. Using a PBM, how do you ensure that, for example, that the consumer, the end user, the patient, has the right kind of incentives? Because you were talking about having skin in the game, but yet we heard that just a basic deductible plan will not allow the patient to participate in any rebate or discount. How does that work, and how do you interface with the PBM?
I mean, so ultimately, when we do our job really well, our patients stay healthier. We don't provide unnecessarily difficult hurdles financially or otherwise for them to get it. We have a little bit different model as far as I think some PBMs where, and again, I'm going to understate probably what our PBM does for us, but they process our claims, they negotiate with the pharmacies, they make sure we have an adequate network that when somebody goes to whatever pharmacy, they're going to be able to use their Harvard Pilgrim card. We keep the negotiations with the pharmaceutical companies in-house, so we negotiate those. We feel like that gives us a chance to actually work on some of these value-based agreements we have, where in your really highly selected population, people got this much better, therefore that controls all those medical costs you would have had to pay even though sometimes that means we're prepaying for 50 years worth of improvement. But we really feel like we can get in there and negotiate that. We manage the prior auths. We get rid of the prior auths when they're not effective or they just don't seem to be really doing what they're supposed to. Our pharmacists actually look at those and do the prior auths and make sure that they say yes and no. We own it. It's not somebody else that does that. The rebates are driven back into our premiums to keep the costs down. So I think it's a little different than what some of them do. And again, I think does align all of our departments to make sure that we own whatever it is, good or bad, that we're owning that in the company.
Could you talk a little bit more about the value-based agreement? We've heard, and value-based contracting, because we heard reference to that today 2 or 3 times. And it does seem like it's, what we have that is a step away from just a discount off list price system. Right. So I'd like to understand it a little better.
So again, with the PCSK9, not to pick on that one, but it's the one I know best. And it basically, in the studies, and again, skeptical about studies or not, they are studies, there are things that are done, and we're going to assume that, that is the value that they bring to the table, that they can reduce cholesterol in somebody who nothing else works with. I've had patients over the years that I could crank the dose of whatever up to whatever. They were losing weight, they were exercising, and I could still see them heading towards a heart attack cliff. And there weren't a lot of choices. So as a physician, I'm thinking, oh my God, this is great. We can lower cholesterol. I'm not sure that's the end point, the be-all, end-all, because what I really want to do is prevent a heart attack. And I think that was mentioned by Dr. Abramson earlier today. Yeah. But, I don't know that we can wait. We could use it as an excuse, but I don't think it's a reasonable thing to wait 20 years to find out if it really did reduce that. But we took that in and we said, okay, if it's supposed to lower the cholesterol, if that's the best endpoint we can get to, if it's supposed to lower it by that much, and in the real world, when we use it with real patients, it doesn't do that, then it's not as valuable as you predicted that it was going to save lives, it was going to save whatever, because even assuming lowering it by X points was going to, 40 points or 80 points like we heard about today would reduce it by this much and that, and, I know this stuff and I'm starting to get confused, but again, the bottom line is, even if it does that, we're not sure it's going to work, but we'll give you that, and if it doesn't, we want to get some of that back because clearly you didn't reduce healthcare costs. And furthermore, if you say, look, don't worry, insurance company or population at whole, this is only really for 5% of the population. I know as a physician that what the FDA approves it for does not limit or tie my hands. I can use it for anybody I want. And if I'm getting pressure from direct-to-consumer advertising, or, doc, you don't understand, this drug is free for me because I have a coupon, I want that one. And we've gotten rid of I am a believer in getting rid of the drug cabinets in the office, and I grew up with them. And they were great when I was in rural America, and nobody had any money, and I had enough so that nobody ever had to get sucked into what it really cost. But the reality is if all of a sudden, because of direct-to-consumer, because of pressure, because I'm the smartest guy on the street and I know how to use this drug, 10% instead of 5%, well, now that breaks the whole model that this, real value was based on. And now you've direct-to-consumered and couponed up enough that people are using it that don't really need it. So you have to give some of that back so that we can put that into premium, because we shouldn't be paying for that. You didn't even say in your studies that was necessary. So that's the one of the kind of value-based contracts that we have to really try to hold people to what they're promising us when they talk about this.
What are the limits for value-based contracting, or what do we need to make it work?
Well, being able to have somebody say they'd work with us. I mean, I'm still amazed at times that the pharma will come to the table with us, and I think some of the embarrassing, ridiculous stuff that we've seen in the press, whether it's around EpiPens or whatever, I don't suspect anybody in pharma or otherwise gets up in the morning going, I'd like to be the evil one on TV, or rip somebody off. I mean, I have friends that work in pharma. They're not those people. But the reality is that, again, I think those kinds of conversations are saying, all right, you're being reasonable, you're being a partner with us. We really do believe in these studies. We don't think we just are scamming people. We think there's value to the population by keeping people healthy that would have spent money having a heart attack and a bypass and all the other incremental costs to presenteeism and absenteeism and the workforce. It just snowballs. But again, I think if you can get those people to be at the table, understand that if you don't come to the table, people will start pointing fingers of blame. That those kind of, again, having honest discussions, get them to the table. And I would hope there's going to be more and more of that, that there's an expectation that if my car never starts, and I've had to bring it in multiple times, at some point you're going to take my Volkswagen Jetta back and give me something, because it's just the right thing to do.
So Afraim, what other concepts are there out there that are sort of new ideas to address this challenge of controlling costs and making rational decisions about the pharmaceutical benefit?
I think a new trend would be narrower formularies. I've seen multiple carriers, Anthem included, move to a narrower formulary on most, if not all, of its small group business, and starting to also pick up in the large group market as well. And what a narrower formulary is, it moves away from the open formularies of the past that covered all the drugs, where you would have clinical edits on the drugs such as PAs, step therapies, quantity limits, and it still covered a certain number of drugs required by legislation in each category for adequate treatment of diseases as the care of the patient is concerned, but eliminated the high-cost multi-source brands that we see. For example, this year, Crestor, I'm sure some of you know, went off patent.
It's not a toothpaste.
And it's not a
Crestor.
toothpaste.
What is it?
It is a statin used for high cholesterol.
Okay.
It went off formulary, went off patent. So generics were available on the market. So there is no need to continually cover the brand drug when cheaper generics are available on the market at the high cost that the brand is still at. And there's a few issues with this. One, in terms of how we can cooperate more with our pharmaceutical industry partners. How do we get them to see that this is good for the patient in the long run? That you don't need to increase the prices of the brand to try to make money on it when you realize generics are coming out on the market. And two, if generics are coming out on the market, you don't need to keep charging what you're charging for the brand, so that the patients that are still stabilized on the brand drug, can keep receiving it. So I think narrower formularies are definitely something that are helping control costs. We're not having to cover as many brand name drugs that you see very low amounts of patients using, just because they like the brand, even though there are clinical equivalents on the market of.
Right.
We're not having to, with the narrower formularies, we're not having to have the amount of clinical edits that we've had in the past. We're having the preferred generics that there's data and evidence available for, that we have experience with, and data is easily available to the patient, while the newer brands that we don't have as much experience with, or the brands that we do have experience with, but the same drug is available as a generic on the market for a lower cost to the patient and to us on higher tiers, so that we can encourage use of those generics versus the brands. So we push.
Is there greater patient acceptance of the narrower formulary today than there might have been 10 years ago, 5
I would say
years
it
ago?
depends on the market. In some markets, for example, a market like New York, I manage 2 markets, New Hampshire and New York.
Okay.
A market
We're
like
just
New
the
York,
same, I'm sure.
Yeah. Identical. A market like New York, you'll see that the majority of the population loves their brands. They are a brand population. Even if there's a cheaper cost generic on the market, they want to stick with the drug they saw on TV, and that makes them happy, even if it's a greater cost share to the patient in some cases. And in other markets, you'll see that as soon as a generic comes out, that use has shifted completely from the brand drug, and the brand drug drops from your top 25 drugs in usage and utilization to it's off the radar completely. So it really depends on the market and the population that you're looking at.
Okay, while I still get to be the one asking the questions, I want to ask about transparency. So we've had that subject has come up over and over again today. And in one context, it means transparency in terms of access to clinical trials and the data, patient-level data. But in another context, it means transparency about price, about this net price that doesn't seem very transparent today. What do you guys think about transparency initiatives? And I'll let Bill go first on this one.
I think it's fair. I mean, I really think it's fair for everybody that's a consumer, whether you're the employer or the person buying it yourself on the individual market or whatever, to know what makes up this, what's in the recipe. And I really think that it's okay to, whether it's the cost of a medical procedure. I mean, I'd heard again today that there's discrepancies around requiring the same level of information about a medical procedure, whatever. I mean, we do require that kind of thing when new procedures come out. I think it's fair to ask about rebates. I think it's fair to ask about net price. What is the net price for these kinds of things? I think it would be very fair that if we were in some sort of a crisis, like I think we are in terms of healthcare costs, rising costs, whatever, to say, well, of the top 50 drugs, wouldn't it be reasonable to know what makes up that cost? The lost revenue that you didn't get from a drug that required X amount of R&D, the cost to produce that drug, the cost to market that drug, all the costs that go into it. Why does it cost $100,000, for Hep C drugs? And then let people decide, without sharing proprietary information, is it really worth it? And I think, again, open discussions about it allows people to have those kind of conversations to, like I would shop for a car. I mean, I have way more information about shopping for a vehicle in terms of what's under the hood than I do right now. And I think a lot of the stuff that comes out, and we are, wherever we're at, I like new, but I usually like to see and improved after that. And when it just comes out new, take my word for it, I think that's a bit of an issue. And we ought to know, well, what about the improved side, whether it's the studies or the efficacy, or what does it really cost? And net, what are the net costs to the insurance company, to everybody else? Again, it's opening a lot of doors that can make everybody on every side nervous, because it's so complicated that I'm afraid that somebody's going to point out something, and before I have a chance to explain it, that it looks creepy. But I think we do need to open the doors. It's gotten too expensive not to.
Well, is that going to happen by itself? Or what would need to
I heard people up here today
about?
talking about it, that, I think we ought to have those conversations and talk about it. I think if it doesn't, I'm not a big legislative blunt force instrument, because I think there are always unintended consequences of everything we do. But I think if we had to legislate to do that kind of thing, and throw in there the direct-to-consumer, throw in there the coupons, and really have civil, non-screaming, non-you're-evil conversations about what is this really costing us? Is there a way we could all do okay and afford to get the care I need and afford the premium I have to pay for my insurance?
To echo
Yes.
Dr. Brewster, sorry to cut you off. Transparency is a really hot topic. Everyone here has been talking about it, and I do agree with you, Dr. Brewster. There is a large need for it on all fronts, not just with the pharmaceutical industry, but with the payer market. And I think with transparency comes a deeper relationship between the partners in the healthcare delivery system. If we know what our partners in the pharmaceutical industry are doing, we can better provide the same services at a lower cost to our consumers. If the consumer knows what a drug costs, they can make better decisions about, do I really need this drug based on its cost? Is it really going to improve my disease or my condition based on the data that's available with it, which ties back to the earlier panels for the need for more data, more transparency in terms of how a drug is tested, how much it costs in R&D, how much it costs to get to market after R&D, the approval process with the FDA. There does need to be more transparency, and I think with more transparency comes the ability to do a better job delivering a quality product to our consumers. You look at, for example, Hep C is a hot topic. You look at drugs today, there's two different therapies that I'll use as an example, Harvoni and Sovaldi. Harvoni is a drug we have experience with. It has a very high cure rate for Hep C. It costs about $38,000 for a course. Sovaldi is a newer drug. We don't have as much experience with it. It does also provide a cure, although we don't have as strong of evidence on it as we do with Harvoni, but it costs 3 times as much as Harvoni. Why? If they both provide the cure, if the manufacturer for Sovaldi says that it provides the cure, why is it 3 times as expensive? So that's information that would be useful in making determination of us as the payer. Okay, where do we steer our patients in terms of a Hep C patient? Should they use Harvoni or Sovaldi? And the general public as, okay, I have Hep C, which drug should I use that'll provide the clinical benefit that I need? And I think there's a great need for that today.
And I think having the ability so that as a physician, I'm not being forced into a corner because of the direct-to-consumer advertising. I mean, we're busy, we're seeing patients, we're under the pressure to not be in the room too long. But when somebody comes in and asks me for Jublia, and I probably shouldn't be using brand names, but it's one of those creepy ads on TV that I don't mind treating toenail fungus, don't get me wrong. It doesn't creep me out at all. But the ads are creepy, but they stick in your mind.
Totally, yes.
I mean, if you see a toenail playing tennis, there's no way you can't remember that. And if it costs thousands of dollars versus tens of dollars, the cure rate is 20% with the thousands of dollars, and it's 80% with the tens of dollars. If I'm an insurance company, I'm just trying to rip people off and save money. I don't want to spend for the TV ad of I want my toenails to play tennis. And if I'm the doctor, I clearly am not up on the latest stuff, because if I was, I'd use Jublia. When the reality is, we need to have those kind of transparencies to say, and here's the freaking cure rate. It's 4 times as much for a millionth of the price. Doesn't that make sense? Shouldn't I have that as a consumer without having to go to med school? And we should make it transparent enough so it's okay to have those discussions, that the patients would expect me as a doctor to be caring about what things cost versus the cure rate, the value, the true quality over cost.
Yeah, and it sounds like transparency is also sort of a predicate for this value-based contract.
Yeah.
Okay.
I think to end on this subject,
Toenails?
Tennis playing toenails. You had the best quote of the day then. I want my toenails to play tennis.
I think the value of transparency becomes even more crucial in the situation where you don't have a cure, where you have a very rare disease that affects very few patients, but it's a very emotional disease to have, not just for the patient, but those around the patient. So it does get a lot more attention from the public, which it should. For example, a disease like Duchenne's muscular dystrophy, which is a degrading muscle disease of increased weakness that affects mainly boys around age 4. There's a new drug out on the market for it called Exondys. Very, very expensive drug. The manufacturer came out with it, and it was expected to be the miracle drug that would give these patients finally some relief in their lives. But after it came out, we realized that the cost of the drug is around $850,000 a year for a 30-kilogram patient. The benefit realized by the drug is minimal at best. It's not experienced in every patient. And when it comes to translating statistical data, which was advertised by the manufacturer, into clinical benefit for the patient, there was a large disconnect. So I think for transparency in a case like this, it it would have been key to see, okay, where is the clinical benefit that you're seeing? You're saying that this
Yeah.
improves this, this, and this, but how does that improve the lives of the patients that have the disease? I think that would have been key data to have in terms of transparency from our pharmaceutical partners.
Wow, that's a powerful example. Do we have questions from the audience?
Yes, there are a number of questions that have come in. I think these first ones will be fairly brief answers, if possible. Dr. Brewster, is dealing with the drug costs your top priority right now? And if not, what is?
I think it's one of the top priorities for us because it is driving up costs across our markets. When I go out and look at the financial reports, we have a lot of provider groups that are on alternative payment models, risk contracts, and whatever in New Hampshire. And so because they're at risk, because they want to know how they're doing, they're in other models with Medicare and other payers, they're basically on the hook for what they're spending. I look at the line items, and again, it has become pretty evident, however you slice it, that our pharmaceutical costs are typically twice what the inpatient line is out of those 4 lines that you've seen today for us. And that's not adding into any of the specialty drugs that are infused or done in the hospital setting. So yeah, I would say that it's a hugely hot topic to make sure that we can afford to keep getting the new medications to the patients that need them. Because, again, as a physician, some of these drugs are absolute miracles that are much better than what we've had before.
Great, thank you. And for Mr. Botros, what's the number one thing that needs to change to control RX costs?
A holistic approach from everyone involved. I think that we can't isolate one party or one issue as being the fault at increasing drug prices. I think everyone can pick up some slack, us the payers included, and I think that more transparency and partnering, not to just point the finger and blame, well, he increased the drug price, so I had to charge more for it, but saying, why did you increase the prices, but here's what I can do to what can you do to decrease the drug price, and here's what I can do to decrease it even further so we can provide it at the lowest cost to the patient. I think everyone should be involved and everyone should be able to come to the table.
Regarding price transparency, a member of the audience had this question. Does price transparency violate confidentiality clauses between the payer and the pharma?
I would say, I'm not an actuarial person or expert. I would say that in certain cases there are agreements that must stay private for the sake of competition. If your competitor knows what you're paying for something, they can match it or even beat it in some cases. But in certain cases it does help to have that price available to the public as well. So I think it depends on the case. It depends on the population you're dealing with and the type of plan that you're dealing with, whether it's fully insured or ASO.
And I'd have to agree. I mean, I think that there's certainly, in any negotiation you're doing, there's a certain amount of proprietary and anti-competition kinds of issues that come into play. And then again, if it's level set across all the payers so that everybody plays by the same rules, some of those things could probably go away if you weren't disadvantaged by revealing that, or if people just wouldn't negotiate with you if you shared what the result of those negotiations are. And again, we're always trying to keep the premium down by negotiating what we can, and whatever we have to do to do that. Right now, in some cases, I'm certain that's the case.
Another topic that has come up in all of the panels today is the fact that there's a pharmacy benefit, and then there's also drug costs that are assumed in a hospital setting or other types of setting. Can you guys talk a little bit about how that gets priced and how the benefits compare between those two items?
Again, medical benefits versus pharmacy benefits. Pharmacy benefits, typically, if you have insurance, you know that there's a copay or co-insurance, there's tiers. As the drugs get more expensive or less available or less competition, they typically go up in tiers. And there's maximum out-of-pockets. On the medical benefit, they're typically infused drugs that are given in a setting where they're not self-administered kind of medications. You don't pick them up at the pharmacy. And those typically, similar to going in and getting surgery or whatever, apply towards your medical benefits, your deductibles, your maximum out of pocket for the year. So there's a difference into what part of your policy that those are attributed to and how they're priced.
I think to go along with what Dr. Brewster said, this is a hot topic for payers. It's something that we've been working on in the recent past and into the near future as well, to try to make sure that drugs are in the appropriate arena.
Right.
Drug prices, when it comes to the medical benefit, tend to be higher across the board for the same drug. And that's simply because if you administer a drug under the medical benefit, if a doctor is administering the drug for you, you are not only paying for the drug,
Right.
you're paying for the nurse, you're paying for the doctor, you're paying for the hospital or infusion center that the drug is being administered in, you're paying for extra costs, so it's going to cost more. Not to mention that the hospital or the physician that's providing the drug doesn't have the same bargaining power as your retail pharmacy that you're getting it from, etc. So I think a big avenue to try to control drug costs into the future would be to focus on how a drug is administered. If it does need to be administered through the medical benefit and it needs an infusion by a physician, there's nothing wrong with that. That's needed for the patient's medical benefit. But if it does not need to be, there's something to be done in terms of shifting that cost over to the pharmacy benefit and avoiding those extra costs.
We have time for one more. We haven't done had a lot of discussions today about overprescribing, but to the extent that overprescribing exists in the market today, what is the role of the insurer?
I think the insurer's taken on a greater role than it has in the past for overprescribing, especially with the performance-based incentives or payment that we are starting to see with multiple payers in the market, where if a doctor reaches clinical guidelines set by a third party for their patients in treating a certain condition or disease, they are paid a certain percentage more than they would be if the patient hasn't reached that clinical benchmark. And this translates over to the medical benefit, where if we're seeing overprescribing for a physician, it should be addressed in terms of fraud, waste, and abuse. Is the prescriber really prescribing the right drug for the right patient? And two, is the prescriber really need to be prescribing that drug? If it is medically appropriate, are there more medically appropriate options on the market? And a big drug category that this deals with is antibiotics. Overprescribing is a large cause for antibiotic resistance that we see today. And it's something that payers are taking a closer look at because it not only affects our patients and our populations, but it affects healthcare costs for us in the long run.
And again, when I speak, and I speak with a voice from an insurance company, sometimes it's all about you just don't want to pay for things. When you look at the reality, we've had patients come to us as new members who are on 13,000 milligrams equivalent of morphine a day. Take my word for it, that's an immense amount of morphine. It's not to say that people don't have pain or don't need pain meds, but when you look at national studies, these are not payer studies, national pain studies that talk about more than 50 to 100 milligrams a day of morphine will increase your risk of dying by, and I'm going to get this wrong, but 4 to 10 times the risk of dying. All other diseases that you have the same with somebody who's not on that, that is huge. And to take that to 13,000 milligrams, now that's an extraordinarily weird example, but again, is it fraud and abuse? Is it the fact that somebody's never really talked to that person about what are you getting out of this, and taking the time to say, there are alternatives. I trust you. I know you're not ripping us off. I know you're in pain, but couldn't we probably make your life better by figuring out a safe, sane way to get you down on this, and having quantity limits, not allowing mail order, reaching out in a partnership to providers instead of calling on in the police and saying, what makes this person different? Because they're really outside of the norm. And as a physician to a physician, explain to me why this person is different. I actually reached out to the provider that was giving this person 13,000 milligrams a day, and he said, please, God, help me. He didn't call me God, but he said, please, please help me. I would love to have help with this person. I don't know what to do. And we were able to get them to a pain clinic and actually start to work with them on getting them an even better quality of life with less risk of dying. And again, it's just having those conversations and identifying that nobody's being evil, most people aren't. We do have cases where we have to send them to our special investigation unit, and there are those cases. But I will tell you, I have an easy market in New Hampshire at least. Most of the providers do a really good job and really want to do the best thing. And again, our job is to basically identify the outliers, I think, and try to work to help that.
I think especially, just to tie off, sorry, Commissioner, I know you're about to tie off. Just to tie off with what Dr. Brewster said, opioid use in New Hampshire is a hot topic. And I think it goes back to my point earlier about balancing our relationships. And I think it's an area where we can really leverage our relationship with our providers to make sure that patients are getting the drugs they need, not that the drugs that they want, and that the drugs are being used for safe and appropriate therapy. And it's an area that definitely needs a lot of attention.
Well, thank you, Mr. Botros, Dr. Brewster.
Thanks.
This was very illuminating. Thank you for participating.
Yes, and thank you, Alex, for
Yes, thank you.
moderating this panel, and thanks to our panelists,
Thank
Dr.
you.
Brewster, Mr. Botros. Thank you very much for joining us. And really, I'm glad you brought up the opiate matter, because it is a huge issue nationally, but it's even huger here in the state of New Hampshire, and something we all have to be totally aware of. This brings us to the end of our event today. I hope you've all gotten a lot from it. I certainly have. Before we end the event, though, I did notice that there was one person in the audience that's on my staff that I didn't introduce this morning, Al Kuchar, who he's our healthcare coordinator. And I'm sorry, I just I'm not really good at this protocol, so. We are going to be, this is a public hearing, and we are going to be accepting additional written comments until November 18th. Those should be sent to Danielle Barrick, and somebody says, at least here on my script, that her contact information, and it's up there, way! That's Danielle's contact information. So if anyone has additional comments, additional questions that you didn't get out there, or whatever, please send them to Danielle so that we can incorporate your thoughts as part of the final report that's going to be published in December. Yeah. Anyway, any questions of me? Any comments from anybody before we close this afternoon? Thank you for being here.